What are genetic mutations?
So to explain in a more in an easier to understand manner, so all cancer, including MDS, is caused by changes in DNA. So DNA makes up the part of how your organs are formed, tissues are formed, and this DNA is replicated whenever new cells are made. So when there's a mistake in the replication, there is a mutation, and that mutation is called genetic mutation. So when that genetic mutation happens, the cell that contains that genetic mutation or DNA change undergoes a malignant transformation. So they gain an advantage to grow compared to other neighboring cells. So they grow more aggressively, faster, and they form a tumor. That's how you get a cancer. So if that happens, that mutation in DNA happens in the lung cell, then you get a lung cancer. If that happens in a blood cell, then you get a blood cancer, something like MDS, lymphoma, leukemia.
Genetic mutations um, are changes to the DNA sequence within cells. There are mainly two forms of genetic mutations. One, acquired somatic mutations that are not inherited. Then there are also inherited mutations or germline mutations that can occur. Overwhelmingly, the majority of mutations that occur in MDS are somatic acquired mutations. They come in a range of magnitudes, essentially. You can have a very small base substitution in a gene that then changes results in a point mutation in a protein. Or you can have these great big chromosomal changes that occur in MDS patients. And so these mutations, these genetic alterations, affect blood cell production. They can give us information about prognosis for patients, potential treatment for patients.
What is cytogenetics?
So, cytogenetics look at the chromosomal structure, generally in the bone marrow cells. And so, before we had mutations that we would look for in individual genes, cytogenetics were really the only sort of marker, or one of the markers, that we use to risk stratify MDS. So, each one of us basically should have, 46 pairs of identical chromosomes or matched chromosomes. But in MDS patients and in patients with other bone marrow malignancies, pieces of these chromosomes may be rearranged or may be missing. And depending on what we see in terms of chromosomal rearrangements or deletions or sometimes additions, that can also help us to determine prognosis in a patient who has MDS.
I talked a lot about mutations in the blood. And so there's the genetic changes that occur that then drive MDS, other cancer types. In addition to that, another main player is chromosomes. So, if you think about a disorder like, Down syndrome, Down syndrome is a chromosomal driven disorder where patients have 3 of the 21 chromosome. What happens in blood cancers is in the blood itself, not in all of the chromosomes, but in the chromosomes in the blood itself, there is either a loss or gain that can occur. And, sometimes it's multiple losses even. But these chromosomal changes that occur drive, better risk sometimes or worse risk. And cytogenetics, or what we also called karyotyping, is basically the way that we look at a patient's chromosomal makeup to be able to get the information that we need to then make therapeutic and prognostic decisions.
Why is it important for someone with MDS to understand their genetic abnormalities?
It can help to influence prognosis, or obviously tell us a lot about prognosis. Also, occasionally when we're doing this testing, we may pick up a genetic mutation that we actually do think was inherited and which may have a risk associated with it in terms of prediction for other cancers. So sometimes that mutation may need to be looked at more closely, and family members of that individual may even need to be tested.
We have a couple of mutations that we have targeted therapy for. So that's one way it can determine the therapy. Second way is if a patient has a mutation that's known to cause very poor prognosis, then we somewhat know that they may not respond to chemotherapy as well as someone who does not have that mutation. So in that patient, rather than trying out our traditional approved chemotherapy, we may push to enroll them in clinical trials because oftentimes clinical trial can be better than more established chemotherapy, especially if we already know that a patient will not respond to chemotherapy. Another way would be if someone has a very aggressive MDS with a mutation that we know can cause aggressive MDS, then we may choose to treat that patient earlier and in a more aggressive manner. Whereas if you don't have that mutation, then we may sometimes even just watch without any treatment. A lot of MDS patients may not need any therapy for a while because MDS can stay dormant for a long time. So a lot of patients just get watched. But if you have a particular mutation that we know will not do well over time, then that we may choose to give therapy earlier.
Is it important to know every genetic mutation a patient has? Is that relevant to their treatment?
Definitely yes, from my standpoint. Even though that there is not huge therapeutic or targetable mutations in MDS currently, the prognosis and our understanding of the prognosis based on molecular mutation is there. And so really getting those tests much better help predict what patients are going to do well, what patients maybe are not going to do well, and I think there's certain molecular subsets where, if we know that they're not going to do well, we're really thinking, okay, you might need a clinical trial. One of those is TP53 mutant MDS. And so that's a molecular subset that we really kind of know, is probably, they might respond to therapy, but the response is not going to be sustained. And so we're trying to look, okay, in TP53 mutant MDS, we know we're not going to be able to get a sustained response. Can we do better? And so that's where we're directing patients to clinical trials using new agents to be able to target that. Another example would be, ASXL1 mutations. So ASXL1 is another, adverse risk mutation in myelodysplastic syndrome. And what we know is that, if it is a higher risk patient and we're trying to use what would be considered the standard of care therapy, which would be a hypomethylating agent, we know the response rate in those patients is extremely low. We're talking, depending on what study you're looking at, somewhere between 0% and probably at the highest end, maybe 30%. So another subset where we need to do better. And I think, that's with clinical trials, whether it's with, venetoclax, which is an oral BCL2 inhibitor, or other novel agents. We're able to potentially improve the response rate, improve our ability to potentially get patients to, bone marrow transplants, which is the only way that you can cure myelodysplastic syndrome. And so genetics are extremely important. And like I said, the IPSSM is driven by genetics. And so, without that information, I don't think you can really confidently and accurately feel like you're making the best therapeutic decision and really telling the patient, all the information they need to know about their prognosis.
So there are lots of genetic mutations that will not affect what we do clinically and that we may not know the full meaning of that mutation in terms of its effect on a patient's prognosis. So in short, the answer is no. However, as we're, learning more and more and making more advances, it is possible that a gene that's not relevant today may be relevant down the road.